countries, and then the second is countries with sporadic cases, and the third is cases, countries with clusters of cases, and the fourth is community transmission. And we have now a number of countries with community transmission, and that's why we have developed a guideline that's tailored to these four situations. And please check our website and you will find the 4 C's and the 4 categories and what should be done based on this. But we have community transmission in many countries, and we have said it many times. And then on the issue of lockdown, so-called lockdown, maybe some countries have already taken measures for physical distancing, closing schools and preventing gatherings and so on. That can buy time. But at the same time, each and every country actually differs. Some countries have strong social welfare system, and some countries don't. And I'm from Africa, as you know. And I know many people actually have to work every single day to win their daily bread. And governments should take this population into account, okay? If we're closing or if we're limiting movements, what is it going to happen to those people who have to work on daily basis and have to earn their bread on daily basis? So each and every country, based on its situation, should answer this question. We're not seeing it as an economic impact on a country, as an average of GDP loss or, the economic repercussions. We have to also see what it means to the individual in the street. And maybe I have said it many times, and I come from a poor family, and I know what it means to always, worry about your daily bread. And that has to be taken into account. Because each and every individual matters, and how each and every individual is affected by our actions has to be considered. And that's what we're saying. It's about any country. It's not about India. It's about any country on earth. Even the wealthiest country on earth can have people who need to work for their daily bread. No country is immune. Each and every country has to really make sure that this is taken into account.
Thank you very much. Next question, Associated Press, Jamie.
Hi, can you hear me?
Yes.
Great. Good afternoon. My question has to do with the situation in some European countries. We've seen some signs that countries like Italy and Spain may be sensing that they are reaching the peak, and that I believe the UK also mentioned some experts there, or one expert there mentioned that they may be nearing a peak. I'm just wondering if you have any estimates. I know that, Mike, you said on Friday that there's no way to sort of see the end of this, but what about peaking? Do you see any signs of peaking within Europe? Thanks.
If you just look at the extent of transmission in those 3 countries you mentioned, we wouldn't compare them to Korea or to Japan or to Singapore in terms of their situation. They have much more extensive problems. And then if you compare them to what happened in China, and specifically in Wuhan, which was the most intense epidemic, we did see, rather than basing this on modelling, let's base it on experience, right? We saw what happened in Wuhan after the lockdown, and not only did they do that physical distancing and put people in their homes, but they continued to look for cases. That's the essential difference. They continued to detect cases and isolate all cases, including mild cases, away from their families. But let's assume they've done that. What we saw over a period of days, and I think you were one of the people who asked the question during the Wuhan event, do you think this is stabilising? Is it going down? And for a number of days, we said, well, we can't tell, and it went up and down and up and down. So what we're likely to see, if you imagine the lockdowns and the stringent measures that were put in place are now in place for between 2 and 3 weeks in Italy at different levels in different places, we should start to see a stabilisation because the cases we see today really reflect exposures 2 weeks ago. So the cases you see today are almost like historical, in the same way when we're told that we're looking at galaxies through a telescope, that we're seeing light from 1 billion years ago. We're seeing a reality that existed before. When you count your cases on a daily basis in an epidemic, it reflects a reality of transmission and risk 2 weeks before at least. So in that sense, what we see today is what happened 2 weeks ago. And what we hope to see is those numbers stabilising, which will reflect the fact that exposure started to drop over time. And some countries, as I said on Friday, have seen that through the number of contacts per case. When they've continued to look for cases, they've still done contact tracing. And what they've found through the physical distancing measures and the stay-at-home orders is the number of significant contacts per case has dropped from the 20s to 15, to 12, to 10, to 8, to 4, which means less people have been exposed to that case than would have been 2 weeks ago, which shows people are distancing. For whatever reason, they're distancing. So there are less people at risk from any individual case. If you get those cases out of the community quickly, they'll expose even less people. And that's how you get ahead of an epidemic. So do we hope that Italy and Spain are nearly there on that? Yes. But the way you stabilise and then move to zero, and I think everyone's talked about the curve up, and everyone talks about the stabilisation. The question is, how do you go down? And going down isn't just about a lockdown and let go. To get down from the numbers, not just stabilise, requires a redoubling of public health efforts to push down. It won't go down by itself. It will be pushed down. And that's what we need countries to focus on. What is the strategy now to put in place the public health measures that will push down the virus after those measures may be released? And then how do we take care of people better in a clinical environment to save more lives? So, yes, potentially stabilising, and it is our fervent hope that that is the case. But we have to now push the virus down, and that will not happen by itself.
And if I could just add to that, what I was going to say, which Mike has just said, is we need to focus on the now. We need to focus on what must be done now to get us out of this. And there is this, I understand completely the desire to want to know when we will reach the peak and when we will start seeing that decline. But that will not happen on its own. These physical distancing measures, these stay-at-home measures, have bought us a little bit of time, a little window of time. And that short window has to be used appropriately so that we get systems in place to look for this virus aggressively through testing, through isolation, through finding contacts, through quarantining those contacts, through caring for further patients, because we will still see patients, and many patients are still going to require need, to support other countries that are going to go through this. So the focusing on what we do now is absolutely critical to make sure we use that time wisely, we use that time effectively, so that once we do reach that peak, that we continue to push and suppress that virus down as quickly as possible, but still be ready to find additional cases should they show up. What we've seen in a number of countries in Asia, and that where they've brought this virus down, they've brought transmission down, they're now seeing repeat introductions from outside of their countries. They have not let their guard down. They are still aggressively looking for those cases as they come in and suppressing it so that it doesn't start again. So we need to focus on the now. We need to use our time wisely, and that is to aggressively find this virus and care for our patients.
Thank you very much. Next question is from Nippon TV, Atsuko. Atsuko, can you hear us? Can we try one more time with the Nippon TV? Okay. That's okay. So let's go to Jim from Westwood One. Jim, can you hear us?
Yes, thank you very much. Very good afternoon to you. I would like to clarify a little bit on the chloroquine issue in the U.S., and it should be important to point out that the FDA hasn't approved it for wide prescription by doctors, but only in a hospital setting, and the doctors there can only get it from the national stockpile. But my question is, what exactly was observed with chloroquine or hydroxychloroquine that could lead to the possibility of it being used to treat COVID-19 in a hospital setting? And what do you mean exactly by randomized testing as opposed to non-randomized testing? If you can answer those, I'd appreciate that. Thank you.
Maria will supplement. I mean, there was somewhat people will describe as in vitro evidence in the lab that the drug was active against the virus, but any number of things are active against viruses. Chlorine is active against viruses, but other things are active against viruses. The question is whether they're safe and effective to put in a human body, and whether they will be absorbed and processed in a way that the virus can be attacked and not the body. From the perspective of chloroquine, there were also some small observational studies, one in France, that followed a small number of patients where there was no randomization of those patients and looked at their outcomes. Patients were admitted at different stages of illness, and the outcomes that were really focused on was the length of illness. And the observation that was made was that people, length of illness or length of hospitalization or length of significant symptoms was reduced. No one here is talking about cure. No one here is talking about taking a magic pill and all of a sudden you recover from COVID. Everyone's looking for therapies that will shorten the disease illness, will prevent people going from moderate to severe, and will prevent those that are critical dying. And drugs act in different ways. Some drugs may actually prevent the virus replicating early in the disease and therefore shorten the length of the illness and reduce the progression to severe disease. Once the disease is very well established and in a later stage of the disease, a lot of the damage that's being caused by the virus has not necessarily been caused by the virus itself, but all of the secondary effects, the inflammation, the drug or the organ failure and other things that happen. So a lot of antiviral therapies are focused on getting a person with the disease treated at an earlier stage of disease. And if you look at a lot of the anti-flu medications like Tamiflu and others, their main benefit that has been found for those, again, has been shortening the course of illness. With regards to randomized control trials, the importance of having a control group is to have a comparison. And then be able to stratify your patients, because if I have a drug and I treat a very severe patient who's of an older age with the drug and that person dies, does it mean that that drug didn't work? And if I treat a really healthy young person who's got a moderate disease and they recover, does that mean the drug worked? And I don't think any of us need to be rocket scientists to work out that there are many factors that predict recovery or predict death. And what we have to separate and we have to distill out is what is the effect of the drug itself, not the age of the patient, not the condition of the patient, and so many other factors that can affect survival. We've all been through infectious diseases ourselves and we recover. Is that because we get out of one side of the bed or the other? No, we wouldn't assume that that was affecting the outcome of the illness. There are many natural things affecting illness outcome, including the hard work of doctors and nurses in supporting the patient and preventing organ failure and ventilating the patient. So the difficult thing at this moment is distilling out the specific